This talk is sort of a setup, and maybe should have gone before Zoe and Jeff's talk about how we got to where we are. And it's actually interesting that this is a talk Jose Almeida asked me to give at the IVC meeting in May, with the idea of saying that, you know, why, when I've done X years of fellowship, is everybody else doing the same things I do? Is that not right? And I think if you look at this closely at this talk explains why, other than those people who maybe did X, Y, or Z fellowship, ought to not be the only ones doing venous disease or anything else for that matter. So I don't have any disclosures, but this is problem number one, the traditional ABMS paradigm. And the ABMS fully realizes that although this was applicable 70 years ago when it was created, practice changes, medicine changes, and this is kind of a broken system. And nobody realizes this more than the ABMS right now. And part of the problem with the ABMS is that all of the power, the ABMS is the umbrella organization. All of the power resides in individual boards which are both administratively and entirely financially autonomous with each other. And as a quote in a paper I read, the ABMS functions a lot like a dead atheist. They're all dressed up with no place to go. They're very effective, but the goals are admirable and absolutely needed in American medicine, but it's just an ineffective power structure right now. Because we have these silos of training where every specialty draws a circle around what they own, and they can block any other specialty from crossing into that circle. And that's why there's only 24 member boards, and in fact, there has not been a new member board created in over 30 years, since 1991, when medical genetics was created. These boards do administer a total of 40 specialty certificates and 88 subspecialty certificates, but obviously the scope of medicine worldwide is much larger than 88 subspecialties. The other question arises is, why are we talking about fellowships? Almost everybody in this room has already completed their training. You do what you do well. Why are we talking about fellowships? We need to move this forward now so it benefits our membership, the people in the room. Well, the problem is that this siloed model works for training. And even though our ultimate goal, as I mentioned earlier this morning, is to float the entire boat of everybody who's in this room, no matter what background you come from, in the views of the ABMS, the ACGME, and everything else, fellowships are central. You have to have these training programs before you ever have any possibility of having your specialty recognized. So even though to those of us in the room, the value is getting this recognized, we have to get these fellowships up and running so that we all can benefit from that in having our specialty recognized. But unfortunately, if you look at this, although we draw these circles around it, there is not a single specialty that actually trains in venous disease right now. Although vascular surgery, and I'm a vascular surgeon, has historically claimed venous disease, if you look at the requirements to be a vascular surgeon from the ACGME, you have to do 20 aneurysms, you have to do 10 complex procedures, 30 abdominal vascular procedures. There is absolutely no minimal case requirement for venous disease. You can finish your vascular fellowship having done not a single vein case your whole time. And the experience actually reflects this. This is the experience from 2020, which was the most recent time available this spring when I put it together. But if you look at the venous cases, the average vascular surgery trainee at the end of their training has done 4.5 varicose vein operations. They've done all of 1.4 sclerotherapy procedures on average. They have done a few more ablations, about 9 ablations, about 4 catheter or mechanical chemical thrombectomy procedures, and about 0.1 venous malformations. And yet, this is the specialty that's drawing a circle around what they own, which is part of the outdated paradigm. The other specialty that's very involved with this is interventional radiology, who are truly experts in what they do. But if you look at the minimal case requirement for venous disease, it's to be determined. I've checked this every year for the last 5 years. This has not changed. So to be determined means pretty much we're never going to put a number on this. So I can't see interventional radiology unless enough people call attention to this. This has been to be determined for years and years and years, and it's never determined. And you look at training of our medical students, I mean, how many of you had any exposure to venous disease during medical school? Outside the coagulation system and the complex diagrams, this isn't even covered in medical school. And this needs to change. And I guess you can ask, does board certification really matter? And this is a really good study. There was a systematic review of 13 studies that looked at the relationship between board certification and outcome. And it's a little bit mixed, but the majority of them, 16, suggested there is a positive association between board certification and outcomes. Only 3 had negative associations, that is, outcomes were worse with board certification, and 14 of them found none. But if you look at a specific example comparing board certified and non-board certified orthopedists, there was no significant difference in pain, joint outcomes, mobility, quality of life, anything else. In contrast, you look at board certified vascular surgeons versus non-board certified, there was a significant difference both in mortality and complications, both for carotid endarterectomy and for aneurysm surgery, although there wasn't for peripheral vascular surgery. So I think we can say that at the end of the day, if our goal is to improve patient care, board certification probably does matter. And I think it's something we should all strive for, not so much for ourselves, but for the future of the specialty and to ensure good patient care. And Zoe provided the nice example of the Boston Scientific Vici stent that was recalled after I don't know how many thousands or millions of dollars investments. That was a problem with clinical judgment, not with the stent. The stent was fine. The problem was the people making the judgment about who to put in the stent and what size of stent and where to land it. And that's the problems we end up with, which ultimately hurt patients. This is probably even a bigger problem, is this imbalanced workforce. And Zoe covered this a little bit. You know, it's actually the epidemiology of venous disease in the United States, it's very hard to get numbers on, at least accurate numbers from currently. But there's about estimated to be 250 million with chronic venous disease, 6 to 7 million of those are C4 and above, and 400 to 500,000 actually have venous ulcers. And that's probably the most accurate number there, most recently from Monica Glowitsky's paper that suggested this number probably is accurate. But if you look at traditional venous specialists, and my number are a little bit different than Zoe's number, but even if you use a pretty liberal definition of a venous specialist as a vascular surgeon, an interventional radiologist, or an interventional cardiologist, and just look at the workload involved. If you figured that every cardiologist and every vascular surgeon wanted to do nothing but venous disease, which they don't, I can tell you, that's at the bottom of the barrel for all of those specialties. But even if all of these specialists decided, all I'm going to do is vein disease, that would be about 18,000 patients per year per provider and 495 patients with advanced venous disease per provider. These specialties that are drawing a circle around what we own are doing a disservice to public health and to patients, and that can't continue. These patients are not being treated, and there is just not the manpower for these patients to be treated by what are considered traditional venous specialists. And this is the other argument that we need to take an active role in. Well, that's coming up. But just to review by this, to demonstrate this imbalanced workforce, about a third of venous procedures overall are performed by people who aren't included right now in these traditional venous specialties. And this isn't so much a problem with other people migrating into the field. There's a need for patients to be treated that just there is no logical way that it can be treated by the number of people that's available. The other problem is although surgery traditionally controlled vein disease, when these were open surgical procedures with high ligation and stripping, venous bypasses, and all of the other things, we've had disruptive technology. And most of this disruptive technology was not invented by surgeons. It was invented by radiologists, dermatologists, other people. And this resulted in bringing together all of these other aspects of venous disease that weren't included in traditional surgery, sclerotherapy, catheter-based interventions, all of these other things, which all overlap into the modern venous specialist. The modern venous specialist is no longer a surgeon. He's somebody who's brought together these different aspects of all these different fields that contributed to the field, and we need to change what this looks like. And this has to do with Zoe's concepts of plasticity, which this is really a great paper, which is really the future of modern medicine. If you look at this paper, you look at things like heart disease and pulmonary disease. Well, in the United States, most heart disease is not cared for by cardiologists, and most pulmonary disease is not cared for by pulmonologists. The vast majority of it is cared for by primary care physicians, some of whom devote most of their practice to it, some of them devote less of their practice to it. But most of this specialty care is not provided by the specialties that draw a circle around what they own. And this has to do both within specialties where different people in the same specialty do different things, as well as between specialties where different specialties have this overlap. And this is really what ensures good patient care and patient access to care, is where you don't draw these circles around what we own, but rather the more appropriate thing is to draw a circle around what we train. And that's the problem with every board right now, is this ownership issue. Rather than taking ownership of the field, which is what they do now, nobody's taking ownership of the training. And that's what's really required, is say, we're going to train good specialists from whatever background they come from, but we're going to be responsible for training those people to be good venous and lymphatic medicine doctors. And there is not a single board that exists right now who is going to take responsibility for it. It's not going to happen. And I think it's very telling that we only recognize 88 subspecialties. Phlebology or venous and lymphatic medicine isn't one, but the American Medical Association, which theoretically speaks for all medicine, recognizes 243 specialties, amongst which phlebology or venous and lymphatic medicine is one of them. And let me tell you, the ABMS, as Zoe said, realizes this needs to change. This isn't jousting with windmills. They understand that there need to be fundamental changes in the system, and that's why this is so exciting, because these guys are engaged in sort of looking at venous and lymphatic medicine as a test case for it. And this is the other argument that I mentioned that we need to change. There's been this argument of overutilization in vein care. This is Margaret's Choosing Wisely paper that included over 100,000 patients from the Medicare fee-for-service database. The average number of ablations per patient in this database was 1.9. Outliers, who were more than 2 standard deviations above the mean, were those doing more than 3.4 ablations. And this is what's interesting, and it's been an argument that's been skewed the wrong way. That vascular surgeons were less likely to be outliers than other specialties. But if you look at this, vascular surgeons were actually most of the outliers. So statistically, it was, they were less likely. But just numerically wise, you know, the outliers, about a quarter of them were vascular surgeons, and it was really similar across specialties. People who are out to cheat the system, that's independent of what specialty you're in. It doesn't matter if you're a cardiologist, a vascular surgeon, anybody else. This is equally applicable. The second thing is, has everybody seen this graph before? Nobody seen this graph before? This is a graph that's widely circulated. This was in a presidential address from the Society of Vascular Surgery decrying overutilization in vein care. And if you look at this, there's this abrupt inflection point right here in the early 2000s. Well, this is when thermal ablation was introduced. And the numbers skyrocketed, and this number is always decried as you know, this is a crime, that there's been a 5,000% increase in ablation procedures since 2004. That's the wrong argument, and we need to change it. This isn't overutilization. This is increased access to care for all of those people who weren't treated when this was just a surgical disease. And if you actually look at the numbers, it supports this. If you look at the number of outliers, Joel Crawford defined an outlier as greater than plus minus 1 standard deviation. And if you look at it that way, which is probably statistically incorrect, it's about 22%. But if you use a more reasonable definition of an outlier is 2 standard deviations beyond the mean, this is less than 5% of physicians who are the bad actors. So this isn't a rampant problem with overutilization. Sure, there's 5% of people who are probably going to do the wrong thing at the wrong time, but this isn't most of us in this room. This is appropriate access to care. This is what is needed for U.S. healthcare, not drawing a circle around what we own and saying, sorry, if you don't come to one of our providers, you don't get access to care. Because you know what? At the end of the day, our providers would much more rather out there be doing complex aortic surgery, which, my God, 15,000 people a year die of aortic aneurysms when 200 million have venous disease. Those patients aren't going to have access to care. So we need to change this conversation that this isn't overutilization. This is the direction that the field needs to go in. The final problem, and Zoe touched on it, is this problem of physician burnout. You know, and this current system does not tolerate changes in career trajectories over time. How many people, raise your hand, if you're doing the same thing today that you're doing when you finished medical school or residency? Anybody? Nobody does that. I mean, people's careers change over time, but you're stuck in this circle that whatever specialty you trained in is where you're going to remain the rest of your career. And this, I think, is a big contributor to physician burnout. And Zoe mentioned this study, which was by the Society for Vascular Surgery using this validated burnout index, where 40% of vascular surgeons had at least one symptom of burnout. And the multivariate predictors of this were ergonomic conditions related to being a surgeon. Big one was work-life, personal conflicts, and lastly, work safety concerns. And I think it's really fascinating that 8%, about 1 in 10 vascular surgeons had considered suicide in the last month. And if you look around this room to the 10 people around you, that's an astounding figure that 1 in 10 people had considered suicide. So this current model really doesn't accommodate changes in career trajectory over time, which we need to change that as well. People's interests change, their life changes. You're wasting 8 years of medical training, and the costs of physician burnout are enormous. The Mayo Clinic did a study, and I can't remember the exact figures, but it is millions and millions of dollars that the healthcare system loses from physicians losing due to burnout rather than taking well-trained people and letting them to follow the career path they really want to feel. And the ABMS paradigm just doesn't talk about this. I'm not going to concentrate on this focused practice designation because Zoe already talked about it, but this is really an experience-based pathway, not a training-based pathway. But it's an incomplete answer. As Zoe said, the ABS isn't going to be supporting this, and what this does is it really keeps these FDPs have to be siloed under a board still. So if you're an interventional radiologist and vascular surgery or general surgery has an FDP, you can't participate in that unless your board also has that FDP on board. And as Zoe mentioned, these are extremely expensive to administer. Part of the reason is I'm a vascular surgeon. I think I was trained in venous disease. Am I going to really pay another $1,000 a year to get another piece of big plastic to hang on my wall that says I have a FDP in venous disease? I'm not going to pay that $1,000 a year. It also doesn't include any standardized training paradigm, and it really does nothing to address these workforce issue, because people who are already doing venous disease are probably the only ones who are going to get this FDP if they want to pay the $1,000 to the American Board of Surgery to do so. So I think the conclusion of this is U.S. medical practice it currently is guided by this outdated paradigm, which even the ABMS understands is no longer valid, and that we need a new model that recognizes venous disease as a well-defined specialty of venous disease, provides adequate training in venous disease for the future, and allows some long-term career flexibility for physicians in general. So thanks very much. That's all I have on that.